Today, I'm not going to give a talk because Pastor Jeremy said it's a time for more questions and answers and discussion. So feel free to ask questions, yeah? And then I can try and answer if I can. We have other medical practitioners, as our brother was introducing himself. So, and I'm sure many others can contribute. So it's really a time for us to talk about, what we are going through probably, and if there's anything you want to ask about, especially about older persons, mental health in older persons. We've got a young person as well. You can ask questions about your parents or whoever. So what I'm going to do is in the beginning, just as an introduction, just give some introductory remarks, just to stimulate some thinking, and then it'll all depend on how you ask questions. And if you don't ask questions, then I'll have to speak more, and you don't want to be hearing me all the time. Okay, so just as an introduction, I'm sure many of you will know, older citizens are special people. I'm in that category now. We have our parents, grandparents, veterans. My mother is still alive. She's in India, and she's 96. This November she'll be 97. God allows. So, and she is still quite healthy. She still does the cooking. Won't allow anyone else to go into the kitchen. And she keeps her mind active as well. So that's my mother. But my father passed away in his 80s with dementia. So it shows the difference, and how we are all different. So, but they are special people. They have brought us up. They have contributed to our nation, or nations, wherever we have come from, nation building. They have suffered many things, as you know, older people, through the times that they have gone through, compared to many of us younger people. I'm also old, but comparatively younger people, we have had it easy when you compare to many of our older people, what they have gone through. And they have sacrificed a lot. And as you know, as Asian, many of you are Asian parents, and we've had grandparents, how we more sacrifice for our children very often. So it's our turn now to look after them. It's our turn to look after them. And it's part of the aging process that we become frailer, physically and mentally. Am I right? Yes. That's part of a natural life that we have to accept. And because of that, we become susceptible to all kinds of diseases of the body and our mind. As we grow older, we become. And disease in one area, this is the other thing that we need to understand. Disease in one area of our being, let's say it's a physical illness, it can affect us mentally. Yeah? It's easy. Just think about, for example, I don't know how many of you suffered from COVID. We talk a lot about COVID. That affected so many of us in so many different ways. Or if you didn't suffer from COVID, I'm sure sometime in your life you've suffered from flu. Yes? Anyone who has never suffered from influenza? Right. So when we have a little virus that affects our body physically, we have an infection. How do we feel? We've got fever, we've got pains, joint pains, aches and pains all over our body. We lose our appetite, yeah? We become tired, fatigued easily. But what about mentally? At that time, do we feel like socializing with people? Do you feel like coming for a meeting like this? Do we feel like going to church and worshiping God? So it affects us emotionally. We feel a bit down. It affects us mentally. Our thinking is affected. We're not as alert. We can't probably remember things as much as we used to. We can't process things that are going through. So just imagine a virus affects our body, but it affects our mind, and it also affects our soul, our spirit. Yeah, we don't feel like that at that time when we're going through a flu. Do we feel like sitting and reading our Bibles and having devotional time? We don't. See, so because we are made to function that way as human beings, even though we talk about the body, soul, and spirit, God has made us to function as a whole. Yeah, and one problem in one area affects the other area. Right? That's the way we are made. So as we get older, we are susceptible much more to all kinds of physical illnesses, and it affects us mentally. Similarly, mental problems then can have an impact on our physical being. Yeah? Okay. So, any questions so far in what I've said? So as I said, I don't want to be lecturing. There's a time for questions, answers, discussion. What I've said so far, any questions or thoughts? No, yes, please. That's the way.
How if an elderly person has access to quality
Maybe we suggest a person come up
Use
here.
a mic.
Yeah, come up here.
Is there
and use
is
the
there a
mic.
roving
Yeah,
mic?
so that
Yeah,
everybody gets to
can hear.
listen.
Yeah, please do.
I just,
Stephen, how to
I mean, it's okay. I just wonder if
No, speak into the mic so that everybody can hear.
Yeah.
not hear me, I'm not loud enough.
Or you can use this.
Oh, no, I'm just
Yeah.
wondering.
Yeah. Oh, very good.
I'm just wondering that if you have an elderly person at home who is unwell,
Yeah.
how do you uplift them? How do you bring them out of, when they're unwell, they don't want to eat, they don't want to exercise, they don't want to go out, So how do you encourage them to get over, that phase that they're going through?
If it's a phase, they will go through it. You're talking about a physical illness that has affected them? Or
Yes.
A physical illness,
Yes.
yeah. So at that time, I think yeah, okay, that problem. Just like if you're going through an influenza or an infection or a chest infection or a tummy problem, or even something more serious, if they're having if they're going through, they've had a recent heart attack or whatever, that's a time where probably we can't really get them to do many things. I mean, I think what we can do is, as a carer, as a family member, is to empathize with what they're going through. That's what people often look for, and encourage maybe in little things that they can do, and understand that other things, because of this, what's they are happening, they will come out of it eventually. But all that we can do is be with them in the journey that they are going through. See, I think I've mentioned this previously. Very often, I am that kind of a person. Okay, I've been in positions of responsibility. People have always come to me to solve problems. So whenever somebody is talking, immediately my mind is working. How can I solve this problem? To the point that my children often say, "Dad, I don't want you to be solving my problem. I just want you to listen to me." Yeah. So we become very often what we call solution providers. But what people want as they're going through problems and difficulties is what we call fellow travelers, not solution providers. Can we believe that? Can we take that on board? Yeah. So one good thing I can tell you today, if you don't learn anything else, what people want, all of us are not professionals. We are lay people, right? So what people want are fellow travelers, not solution providers. All right, let's go on. And I said, please, I know people will be reluctant. You have to come up here and ask questions. But you can, even from there, if you speak, and I can probably repeat the questions if you're reluctant to come. So just a bit more facts. The population of people aged 65 and over has tripled over the past 50 years. Tripled over the past 50 years, right? And what is forecast is that it will triple again in the next 50 years. Do you get that? It is already tripled in the past 50 years, and it is going to triple again in the next 50 years. People over the age of 65 and over. Why do we use this term 65? You see, when my father worked in Singapore, and at that time, the retirement was 55. 55. He retired at 55, and then he wanted to always go back to India, went back to India. Still young. These days, we would consider it still young. So why did 65 was chosen? Because in the Western nations, that was the age when people used to retire. So that's what's considered as used for geriatric medicine, for age psychiatry, for everything else. 65 was used as the term. But now, as people are living longer, we might have to push that up even further, what we call as old age. So currently, the definition is someone who is between 65 and 75, we call them young old. 65 to 75. So I've just reached 75. Okay, so I'm still young old. Right? But 75 to 85 is supposed to be old. And 85 to 95 and over is old. Okay, so these are just terms that I use so that people know which category you fall in. As I said, it might have to be pushed as people are living longer now everywhere, not only in the West but also in the East. Okay, so it will triple again the next 50 years. The numbers are enormous, not only in developing countries but in developed countries but in developing countries. Look at China, right? India, people are now living longer. And especially China, the whole thing is changing because they had one child family. Now there are less young people, many more older people. Yeah, so the whole population is changing. By 2050, well, not very far from now, 2050, 25 years, 2.1 million people will be aged 65 years and over. 2.1 million people. Billion, not million, billion, sorry. People will be age 65 and over. The fastest growing proportion will be people, what age? Out of this, which is fastest growing you think? Come on, what do you think?
Young old.
No, 80 and over will be the fastest growing proportion of people. Yeah, just think. That's why I said we might have to change the definition of geriatrics and aged care. If not, it'll all be swarmed with people even in the 65 age group. So with the shift in this demographics, older people will overtake infants as being at the greatest risk of disease and disability. We often used to think, oh, little children, of course, they are much more vulnerable to disease because they are more susceptible to infections, and because they are young, their brain has not matured, their heart has not matured enough, the lungs have not matured, so they're susceptible. But by 2050, it will be overtaken by older people. Around 14% of adults aged 60 and over live with a mental disorder. Around 14% of adults aged 60 and over live with a mental disorder. I'm repeating that for you to know how common mental disorders are in older people. And what do you think is the most common mental disorder in older people?
Depression.
What do you say? Dementia.
Depression.
Depression. Anything else?
Loneliness. Lonely.
No, that's not mental illness, but it's a social, psychosocial. It causes, many of these things. Any other thoughts? Any other? No? Dementia, depression. Anxiety. Yeah. Okay. So actually, we often think when older people with dementia, but the most common conditions are depression. So the three that has been mentioned are the most common. Depression, anxiety, and dementia are the most common. mental disorders in older people. So I'll come to what is the most common. So globally, around the whole world, a quarter of deaths, around the world from suicide are among persons 60 and over. A quarter of deaths from suicide, 25% of all suicides are people over the age of 60 and over. So there's a high prevalence or incidence of suicide in older people. Any comments, questions so far? They said, this is supposed to be, not me just talking. Any thoughts, questions?
Among the people with suicide, is there any gender
Difference? Yeah, there is. So, in the younger population, so suicide is most common in younger males and older males. So the young men and old men are the most common, vulnerable for completed suicides. But when it comes to attempted suicides, females are more common. So why? Because men, when they commit suicide, they do it in means that they either jumping, hanging, right, shooting themselves, farmers. But women often, it is probably overdose of tablets. They can then probably be saved more easily than men do. Okay? Somebody was going to ask another question somewhere. Yeah.
You just answered my question. I
Okay.
just wanted to know the
Form of.
because at that age, 60 and over, youth. I mean, where do you get a gun or the
Farmers
form-
often do have gun if you're isolated.
The way.
So that's why I said, so more old, it's men on their own very often. Go into the car, carbon monoxide poisoning, or in their garage hang themselves, or go somewhere from a cliff and jump. So these are things that they can do even in old age group. Yeah. Okay, so let's go on and then probably.
Got a question.
Yeah, sure.
What's the most effective treatment for depression?
Okay, we'll come to that. Let me just, common mental disorders in older persons, for you all to remember, I'm going to give you 1, 2, 3, 4, 5, 6 conditions, all starting with the letter D, so that you can remember, okay? All starting with the letter D. So first of all is depression. Number 2, what was mentioned? Anxiety. Now, another term for anxiety is disquiet. Disquietude is another term for anxiety. So starting with letter D. Number 3, mentioned dementia. Number 4 is a condition called delirium. Have you heard of delirium? Yeah. See, what is delirium? I will just cover it now because it's quickly. Delirium is an acute confusional state, and usually due to medical problems that are happening. It affects the brain, and that person becomes very confused, right? Memory is confused, their orientation becomes confused where they are. They begin to see things that are not there, hear things that have psychotic symptoms. So the two most common groups of people to become vulnerable to delirium are young children and the old. Why? In the young, the brains are still not developed. So because of that, any poison, any stress, anything that happens, even like a simple infection, can affect the brain and make the brain confused. Are you with me? Similarly, the other end is the older people. Now, an older person's brain is degenerating. And because it is degenerating, it becomes much more susceptible to all kinds of physical or emotional insults. In my specialty, have come across old people who have become delirious just because they have got a urinary infection. A urinary infection won't make you and me normally become confused or delirious, but an older person, because their brain is degenerating, it can cause confusion and a delirium. I have seen patients even with just simple constipation becoming delirious. Right? Okay, so that's why delirium is more common in the young children because their brain is not fully formed, and in the older because now the other way, the brains are degenerating. Are you with me? Yeah. Any questions, sir? Yes.
How do you slow down degeneration of the brain?
That's a big $1 million. If I got the answer for that, I'll be a millionaire. I will be a millionaire. But we'll talk about it. Let me so what did I say? Depression, disquieted or anxiety, dementia, delirium, and the fifth one is what's called delusional disorder. You've all heard of schizophrenia, yes? Now there's a special kind of schizophrenia that starts in the older age group, what we used to call late onset schizophrenia, or late paraphrenia was the term. So it's a delusional disorder. It's a special kind of, it's very different from the younger schizophrenia. Okay. And the sixth one is, like anybody, drug and alcohol addictions. So these are the 6 main conditions that we see in old age psychiatry. Depression.
About dehydration.
Dehydration can cause delirium. We are talking about the mental conditions. It's 6 common. There are old people can have all the other mental disorders that young people come, but these are the 6 most common ones that older people suffer from. Okay. Now, so I will go quickly into depression because that's the commonest. Depression is the commonest mental disorder. As the old and very old population increases, the prevalence of depression in older people increases. Depression is usually under-detected, unfortunately, in older people. And because it is under-detected, it is also under-treated in older people. Depression treatments are effective, but require appropriate management. So why is it that older people are much more vulnerable to why depression in older people? One, so some of the reasons, genetic, okay? Now, genes or the hereditary is less important for depression that starts for the first time in older people. It's more of an issue for younger onset depression. Older depression, there might be a part, but it's not as significant as the younger group of people who suffer from depression. Number 2, age-related neurotransmitter deficiencies. What do I mean by that? See, in the brain, there are all kinds of chemicals that pass messages from one nerve to the other. That's how our brain functions. Are you with me? Yeah? But through chemicals. So, as we age, what did I say? Degeneration takes place in our brain. Not only people with dementia, all our brains begin to degenerate, actually. And because of that, some of the chemicals in the brain, neurotransmitters in the brain, required for proper transmission of messages, begin to become deficient. Okay? So neurotransmitter deficiencies. Number 3, cerebrovascular lesions. You've all heard of strokes. Yeah? So when a blood vessel to a certain part of our brain gets blocked, we have either hemiplegia or hemiparesis, weakness on one side, we can't speak properly sometimes, all kinds of different symptoms. But that is if a major blood vessel gets blocked. But what is the other thing that happens is multiple blood vessels in the brain, smaller blood vessels can get blocked. And that is causes and that then can give rise to a kind of dementia. It also can give rise to depression and other mental health disorders because it's multiple vessels in the brain, again affecting the functioning of the brain. Number 3, very important in older people, physical ill health. Physical ill health is a major factor. And older people don't have, when they usually have an illness, not just one illness, they've got multiple illnesses, and the severity of illnesses, the more severe, obviously there's a more chance of it, person being more disabled, giving rise to depression. And neurological disorders especially are much more vulnerable. That means someone who has had a stroke is much more vulnerable to depression. Somebody who has got Parkinson's disease, much more vulnerable to depression. So many neurological disorders, the person becomes much more vulnerable. Then disability. People can't walk properly. People are then constricted going out. Chronic pain, older people, all kinds of things, arthritis, different problems. Independence is restricted as a result. Feeling of being a burden to the family, all this can contribute to disability, can be a major factor for depression in older people. Another factor, alcohol abuse. And this is important. We've got an ex-general practitioner. Medications, prescribed medications. There are several medications that are implicated in depression in older people. Okay? So, one of the things as a geriatric psychiatrist I used to do is, when patients are admitted, so one of the first things is obviously do what we call a screen. Is there anything physically that's going on that could be contributing? The other thing is medications that they are on. You know, older people, what happens? You go to a doctor and say, I've got an ache. Then you go for another reason, infection, another. Urinary problem, another. So they end up with multiple when they come with medications. Half of it is often not necessary. You know, I'll tell you one thing. How many older people are on cholesterol lowering medication? How many of you are on cholesterol lowering medication? Yeah, I'm not saying take it off. But what I'm saying is, very often, if you have got risk factors, that's fine. But we used to have patients being admitted to our ward in the 80s and 90s on cholesterol lowering medication. No problem. Why? At that age, if they've not had a stroke, if they've not had a heart attack, why put them on cholesterol lowering? So first thing I used to tell my registrars is, take them off. You know, take them off. Because it causes more side effects. So, I'm not saying all of you go off. Talk to your medical practitioner. Do you really need? See, these days you go to a doctor. They say, your blood level. Oh, cholesterol is slightly high. You need to go to a cholesterol lowering medication. You know what? I would say this is the biggest pharmaceutical company falsehood. You know the amount of money they have made out of cholesterol lowering. Okay, so don't say afterwards to your doctor, KG said that come on. The doctors have to do risk analysis, and if you just, yeah, sorry, go on.
It can
Right.
be a bit of a dilemma
Yeah,
in terms of general practice. You say doing in psychiatry is slightly different.
yeah.
Because if you face with a patient, especially of a younger age,
Yeah.
if the cholesterol, nowadays we don't look at the total cholesterol. If the LDL is high, and if you not treat it, and say, oh no, don't worry, you're still young. But the thing is, it may be overlooked, and the person will
As a stroke, that will be blaming you for
yeah,
that.
will have that's what they call false positive,
Yeah.
false confidence. So he went on, and then he probably didn't even come back for cholesterol check and say, well, people told me not to take it. So he went on until his middle age of 40 or 50, and then suddenly got a stroke, and then traced things back
Yeah.
towards race LDL, and then it made, who knows, litigation come and say,
Sure. Yeah.
Doctor so and so, why did you treat this person with a family history of high cholesterol and stroke, and then this person even though young, wouldn't it be a good secondary prevention?
Yeah.
You know, rather than be so confident that, oh, you'll be all right, and then, see, there is a
You're in a dilemma as a general practitioner, I agree. See, I was talking about older people.
But
So-
even older people is the same. So if we look at the general trend, okay, nowadays we eat a lot of this junk food, okay, and then if there is a slight, of course we can't say it's family
Yeah.
history. If only one person has a
That's like a
even though
stroke.
without a stroke,
Yeah, yeah.
but diagnosed have a blocked
Yeah.
artery somewhere.
Yeah.
And then if you don't treat it, and somehow he ended up having a heart attack, you know, 3 years later, and they trace back, why did you start treating?
Sure. Yeah,
It's
I mean,
sometimes
it
it can
is,
be a
it
bit
is a,
of
it is a
delicate
dilemma for you.
situation.
I totally understand. As a general practitioner, you put into that, you know, we don't and something happens,
Yeah, that's right.
targeted. I guess, probably, if it's high, let the patients know and say, I would advise you, if they say, I don't want, very often GPs will be pushing, you have to go on. But if the patient says, I don't want to, you know, probably leave it at that, the patient's decision that they have said no. But I was talking more about the older, you know, people in the 80s and 90s, no history of any stroke so far. At that age,
Well,
having a high cholesterol is not then, at that point, going to make them.
I would say always go on a trial of dietary control, exercise, and see whether that helps. And then maybe observe. I suppose.
Correct, correct.
Yeah.
Yeah, good. So we need to have, I'm probably pushing this and saying, because of the numbers that I've seen, and even, I mean, we were talking about, that's another topic, when you talk about diet, you know, in the past we used to say, don't eat fat. But now you're saying fat is good. Animal fat is good. Yeah? It is all carbohydrate that's bad. And the body converts carbohydrates into unhealthy fat. But eating animal fat, you know, my wife throws away all the chicken skin and all that. I take it and eat it. And when you have a chop, she takes away the fat. I said, leave mine alone. Lamb chop. So things have changed. You can read for yourself. You know what people are saying about the whole area of cholesterol. What is it that makes your cholesterol high? It's not just eating fat. You know, people used to go, no butter, only margarine. Now people are going back and saying, butter is better than all this. And then egg, only eat the white, not the yolk. But they're saying, egg is good for you. Yeah. So things are, you know, you find all kinds of changes that are taking place with more information. So I'm not going to press that. But, all right. So psychosocial factors, when we talk about depression, let me ask you, what do you think are the reasons why older people get more depressive illness? What do you think? Loneliness, very good, very important.
Isolation.
Isolation, yeah.
Mineral deficiency.
Mineral deficiencies, yes.
Lack of mental stimulation.
Lack of mental stimulation. Again, due to isolation, loneliness, correct. What else?
Disability.
Sorry?
Disability.
Disabilities, we just talked about it, yes. Anything else? So these are important ones. And what about grief? You're living in a time of life where death of spouses, death of other family members, death of loved ones. So death of a spouse or divorce, important. Recent losses, old age, not just losing somebody else, financial losses, yeah? Independence, loss of independence is a big thing in older people. They've been independent all, driving, now can't, stuck because of loss of independence. In the Western society, maybe not so much in the Asian, but many Asian communities are also becoming more dependent on pets. Do you know how many people used to have, a man had a dog, which is the most important part of his life now, no wife. The dog dies depression. Loss of a pet, very important. Okay, loneliness we talked about. Poor accommodation for older people. Recent move to a nursing home. A number of patients that I've seen, pushed by the family and others for their own good. But that change from home to a nursing home can be a huge stress and a trigger for depression in many older people. Yeah? Scrap heap phenomenon. Do you know what that is? Scrap heap phenomenon? I've lived all my life, been successful in my job, been a provider. Now I feel that I've been thrown on the scrap heap. Nobody wants me. I am a burden to society, burden to my family, burden to society, because they say, oh, older people, we have to provide for them, we have to give them, this, that, and the other. The health service is blocked by old people, all the wards you go. So the feeling I'm an old person, I must throw it on the scrap heap. Right? Ageism, go into society, old. Elder abuse. We talk about domestic abuse, elder abuse. 1 in 6 older person has experienced elder abuse. 1 in 6. And severe life events along with lack of supports. Okay, so let me leave that. As I said, I can go on talking. Got enough things to talk about. So let's have time for questions, discussion on the things that I've said. Yes?
You will find a person's personality like introvertedness and extrovertedness, any implications, any impact on
Personality can be a factor, but see, many of us, whether introvert or extrovert, there are very few who are typically all extrovert or introvert. We are a combination of different things. And in the younger age, the thing is, if you're an extrovert, you tend to come to terms with that and live your life accordingly. It's not going to make you depressed. But along with that, so if you are an introvert, don't have many friends, and now your disabilities and loneliness can probably be a trigger. Not the personality factor by itself, but along with it, other factors that I have could trigger it. Any other thoughts or questions? Yeah.
What is the role of ECT in mental
Oh,
sickness?
sorry. Okay. Okay, we'll come to that. Now, so when we talk about depression, there was another question before about treatments. So when we come to treatments, again, when we talk about depression, depression is a very confusing term, right? Now, these days you go, every other person on the street is depressed. So what do we mean, by the term depression? Even among medical practitioners, the same term is used for a mood. I'm feeling sad. People say we all can have happy times and sad times, isn't it? That is normal life. But these days, if you feel sad, I'm depressed. So is it a mood that we are mentioning when we are saying we're depressed? Or is it a symptom of a psychiatric illness? See, we have depression can be a symptom of many mental illnesses. One symptom, right? So when we use the term depression, are we meaning my mood state? I'm feeling sad, or is it a symptom? Or the same term is also used for an illness, depressive disorder. Okay? So when we talk, so forget about those. When we talk about depressive, it's an illness or a disorder. Again, there are many different types of depression, depressive disorder. There is where we call due to stress, anxiety, a part of anxiety disorders. A lot of people can get depression. Then we have what is called melancholic depression, where a person has more severe depression, which affects all kinds of bodily symptoms, can give rise to, as I said, loss of appetite, loss of energy, loss of motivation. So more, even physically, can be either agitation or retardation. I've seen patients, you talk to them, you ask a question as a psychiatrist, they'll be sitting there can't even answer the question. And when you're going to ask the next question, comes out the answer. Yeah, that's what's called psychomotor retardation. Or others, when you're talking to them, they can't even sit like that. They're up and down. What's called psychomotor agitation. So all these are seen in more severe depression, what's called melancholic depression. And then there's another type of depression, it's called psychotic depression, where a person goes beyond that and they begin to have psychotic symptoms, believing things, what we call delusions, false belief, that cannot be corrected by reasoning. They begin to say, oh, I'm a bad person. And you say, why? So I've done this maybe 50 years ago. Now when they are depressed, it all comes back and you can't convince them. And they say, everything that's going wrong in my family is because I'm a bad person. Yeah? Or, they feel that other, what we call delusions, that I don't have enough money. There might be thousands in the bank that's going to go to their children, but they're sitting there. I've gone to patients' home where they're sitting there without even putting the heating on in the middle of winter, several layers of clothing. You go to their cupboards, no food. And just why? They're convinced they've got no money, but in the bank, thousands. Yeah, but because of their illness, they've got a delusion. They believe that they don't. It's called a delusion of a poverty. Okay, and then they begin to hear things, hear voices, hallucinations, saying how bad they are. Neighbors talking about them. They're convinced that these things are happening. Okay, so these are psychotic symptoms, and that's psychotic depression. So treatment depends on what kind of depression it is. If it is depression that is more due to anxiety related, then the kind of treatment would be more to do with many psychological treatments that they have. There's so many psychological treatments that are available now. You've all probably heard of CBT, have you? Cognitive behavior therapy. So there are many kinds of different psychological therapies. That should be the main focus of treatment, along with many psychosocial interventions that are there, that can be given, telling them to do this, that, or the other. But if it is more severe depression, they might need psychological intervention plus medication. And these are the antidepressants. You've all heard of antidepressants? There are many different types of antidepressants. So the choice will depend on the psychiatrist or the GP, what is being chosen. I don't want to go into details, so it all depends. So what we have to be careful with older people when they're depressed, you're going to be on treatment, is the side effects. Remember what I said? Yeah. They're all much more vulnerable to side effects. And sometimes the side effects can be worse than the illness. They're given tablets which are going to make them fall and have a fracture. And I often say, once an old person falls, fractures, very often the recovery is very, very poor and difficult. Okay? Then they become disabled, recovery. Once they've had operation, if they've had to have all kinds of side effects there as well. So we have to be careful about the side effects. So that's why we have to be careful which antidepressant, what the dose is, often less than the younger person. And if they've got also psychotic symptoms, then we might have to give them, along with antidepressants, what's called antipsychotic tablets. And that's where, in the severe depression, that we consider ECT. When they have not responded to medication, they have become so severely ill, not eating, not drinking, then we consider ECT. And ECT, let me tell you, is a very good treatment for people with severe depression. I've seen remarkable improvements. This patient coming in, not eating, drinking, almost going to die, ECT, they recover completely. So that's the answer for treatments of depression. Yes? There was another question.
What's ECT?
Sorry?
Yeah, what does ECT stand for?
Oh, ECT is the past we used to call shock treatment, electroconvulsive therapy. That's what E, electro, C for convulsive therapy. So it's shock causes like convulsions, yeah. But these days, what we do is we give them medication, so they didn't just get they're given under anesthesia, and muscle relaxant, so they don't have the full-blown like epileptic fit, because it's all modified. They get the shock just to the brain, the treatment part. Yes.
Well, this is my own situation.
Yeah.
Sometimes I think it's very important when sometimes I think doing things. And then sometimes I think family should try and gives me a chance to make my decisions without too much interference. See, prior to my fall, I was going to go back to Malaysia on my own. So now that I have a home, it's only 3 weeks already. So my arms is not my legs.
Ah.
The next thing I get this phone call from my younger brother. He says, "Sam, you shouldn't be going home by yourself. You better bring your daughter with you." So then sometimes I think the time comes when I'm not a child, so surely I should be allowed to make my own decisions. And then he said, "Oh, if you go by yourself, you might fall." And then what he doesn't realize, and people should check it out first before opening their mouth, that I will get handicap assistance. And when I have that, the person who goes with me is not allowed to kind of do that kind of thing. So it's easier, I said to him, it's easier if I go by myself. Because the moment I get to the airport, there is the person coming to pick me up in my wheelchair and bring me, and my passport, my everything, my luggage, all is checked in. There's no interference whatsoever.
Yeah.
So I think that sometimes when like things that my family loves me, I know that. But sometimes I think that when a person I live by myself now alone, they should give the person a chance to make their own decisions. Because psychologically, I'm not a child.
Yeah.
So I might resent it, and that makes me even more depressed.
Difference. Yeah. Thanks for sharing that. It's a difficult area. Certainly, yeah. And it's the balance, isn't it, between the family wanting to feel they're caring for you, but you wanting the independence. So it's always it is a tough one there. But I agree. I mean, as long as you have a capable mind, you're not showing any signs of dementia or whatever, you should be allowed to make those decisions. I agree with you. Very often we think, just because they've lost all capacity or capability to make decisions, that is not right. Yeah, I think it can, as you said, be a trigger for you if everybody is pushing you, not wanting you to do what you should. But the other important thing is, as we get older, is to have, I don't know how many of you have had, a power of attorney that you have, and also decision makers that you can sign up for, and say, when you come to the position where you can't make a decision, very often you don't realize yourself that I can't make a decision, but you have already given that power over to your family member, when probably if there is cognitive impairment, or unable to make decisions, there is somebody who can make those decisions. So yeah, it's a difficult one. Thanks for sharing that. Any other thought? Yes.
Nowadays, I hear a lot of people, friends telling me, "Oh, this person is bipolar, that person is bipolar." What exactly is bipolar?
Okay, so bipolar by itself is not a purely older person's mental health. It is a bipolar affective disorder is what in the past we used to call, many of you might have heard the term manic depressive psychosis. Have you heard of that? No? So that is, now we use the term more bipolar affective disorders. These are people who have the tendency in their illness to 1 minute be depressed, and then they can swing out of that to become what we call manic, elated, full of energy. I've seen patients who are, they won't even sleep because they're energetic, planning this and planning that. And they feel they've got a lot of money. They could be writing checks to everybody. "Oh, I've got money," and giving it away. Okay, and then they are doing things to the point where they can be at risk in society. Driving erratically because they've got now energy. So that's the manic phase. So bipolar affective disorder is people who have that tendency to become depressed. So you might have people who have got depression, but then mania. And then other it could be depression for a long time, and then an episode of mania. But so where you have this bipolar, both the depression and mania, that's what we call bipolar affective disorder. So not all people who have got depression, we won't say bipolar. It's only when they have that tendency. Again, bipolar, there are different types of bipolar. Bipolar type 1, type 2, that's all becoming too complicated. So that's what bipolar affective disorder is. And usually bipolar affective disorder, like schizophrenia, remember I said there's a type of schizophrenia called late onset, which is very different in many ways. It usually starts in younger age. So it's very rare for somebody to have a bipolar affective disorder starting for the first time in older age. So schizophrenia, for example, the usual age when people develop schizophrenia, do you know when it is? Between
30.
teenage, from 16 or 18 to 25. That's when people die. Not saying that others don't, but usually starting age is that. And same way with bipolar affective disorder, if somebody has got a tendency towards it, usually shows up much younger rather than later on in life for the first time.
Would you say that it's genetic or something triggers?
Yes, so both bipolar affective disorder, see in psychiatry, in mental health, we talked about influenza and COVID. So when it comes to physical health, we can say, oh, this is the cause for it. Yeah, it would be a virus or a bacillus or a infection or whatever, maybe rheumatism, whatever, a cause when it comes to physical. But when we come to mental health, it's very rare to find a single cause. So we use the term multifactorial. Multifactorial. There are multiple factors causing this illness. So serious illnesses like schizophrenia, bipolar affective disorders, these are the most severe mental health disorders, functional mental health disorders. It definitely has a genetic basis, all right? But that doesn't mean that the person is going to end up with that illness. It is just like most illnesses these days. For example, diabetes. Do you have a genetic basis? Very often we do. Heart disease. Yes. So many of these disorders, we have what we call a genetic loading because of our parents or grandparents, we are loaded. But that doesn't mean because we have got the genetic loading towards diabetes, we're going to end up with diabetes, will we? Not necessarily. So if we take care of our diet, if we take care of our exercise, physical health, and all that, we might never end up with diabetes. But if we, with the genetic loading, also these other factors that trigger us. So when it comes to mental illness, it is very much a multifactorial disorder. That means, for example, bipolar, you're asking, yes, there's a genetic basis, but along with that, if there are also psychosocial factors, stress, very often, an important factor, and other factors like what we talked about, other factors that have happened, and then ultimately that causes chemical imbalance in the brain, and that triggers the illness. So that's why it's called multifactorial. Any other questions? What time should we end, brother?
We're going for an hour now.
One more question.
Sure, yeah, one or two, depends on the time. I am here.
I'd like to have your comment on whether there's any difference in the number of predisposition of senile depression between, say, developed country like a Western country and undeveloped country like Asian countries, China, India, and say Australia.
You're talking about depression.
Depression, yeah. With particular background factors like, say, Western country, we know the medical standards are higher, so depression are more easily diagnosed and treated, and also because of the pension and disability care, MITS and care plans and whatnot, and also lack of family support. Whereas compared to Asian countries, we have more family support and we don't have all those social disability pension and whatnot. So and also the people tend not to be seeing GPs that often, and then this depression could be missed. So I just want to have a comment whether there is any difference in the degree of senile depression between these few
Countries.
countries.
Interesting question. So let's, for example, use what you're saying. I think generally the incidence would be similar, but obviously in the Asian context, there'll probably be more underdiagnosis compared to here.
There could be overdiagnosed.
In Asian countries, overdiagnosis.
No, in here, because anybody coming
Here, or Australia. Yeah, that's what I'm saying, could be. So, so I think the condition is probably, would be similar, but the diagnosis of it will be probably different because of various reasons, how it is diagnosed. So what, we are not talking about the diagnosis of it here, we are talking about the prevalence. My feeling is that probably, see, for example, the example you gave, here there is more disability services, there is more social services, there's more nursing homes for older people. That is there, which might be a plus when you talk about depression. There are things to care for you. But in the Asian countries, it's changing. There's a family to look after you. So at the end of the day, would you prefer, see, if you say this is good because in the Western society we have all these things to look after us. You ask me, what would you prefer, to be there or be looked after my family? I would probably say I would rather have, if there is family around, to look after me, isn't it? So both have its positives. So and you can't say that because all these social things are not available in the East, but there are other things that are compensated for. So it is not a simple factor. But on the whole, older people's mental illness, I mentioned in the introduction, is under-detected. Because very often they don't go on their own to look for help. Very often, because of multiple pathology, there's under-detection because very often older people's mental health, depression can be, when they go to the doctor, they'll be complaining about their physical symptoms and aches and pains, and because of that, they'll be focused on that and miss the depression that's going on. That's the comorbidities make the depression in older people less able to be diagnosed, unless you're a specialist.
In the studies, bringing all factors into consideration and eliminating the factors like social security and so on, we find out that in Asian countries, large population countries, especially like India and China, compared to say the West, is there such a thing? Really find out, say depression, if you're looking at the whole spectrum, starting at the initial stage of depression in Asian, I mean that's how I feel. In the Asian countries, because of family support, and you may not end up having becoming chronic depression the way you require treatment. So, and that in a way, whether the person need any treatment or not, and we wouldn't really say it's a depression. We probably say just a bit of an upset, causing a bit of a low in mood, kind of.
Exactly.
It's in a way it's depression, just to what degree is why initially it's depression. So it has a very study really looking into that. So.
Yeah, I'm sure there have been, but it's a difficult one to do because many of them, as I said, in Asian countries, don't come to their attention because of various factors. So to find out the real prevalence, you have to do a real, here we have a lot of community studies. It's much more difficult to do that. If you just focus on the people who come to the doctors and hospitals and do a study, it is a walk study.
You have to do proper community surveys. How easy is it going to be in India to do a community survey, going to every home like we do here, to do studies? Very difficult. So I'm sure there have been done pockets of it, but it's much more difficult to find. And even if you go, the families will say, they are all right.
Yeah. Okay. Don't get too technical because the rest of us are not.
Extension of what I just asked this. In China, nowadays people are so conscious about health and longevity. So there's a lot of morning exercises you see in the